Hi everyone, thank you for joining us today this evening for the Target Ovarian Cancer Clinician and Patient Perspective talk. So the reason why we are doing this talk is approximately 7,500 patients are diagnosed with ovarian cancer in the UK every year. And unfortunately, these symptoms are quite vague and we end up diagnosing them quite late. So today we are very fortunate to have Dr. Pawan Randev, who's a GP trainer with a special interest in early diagnosis of cancer. He works in the primary care setting in Leeds and is a Cancer Alliance for the East Midlands. And we're very glad to have him today. Along with him, we have Helen Barker, who is a wife and a mother of 3 grown-up children, who is very kindly has agreed to share her story with us today. So in terms of the structure of today's talk, Dr. Randev will start us off, giving us some information about how to diagnose it and how to try diagnose ovarian cancer much earlier than what we do at the moment. And then Ms. Barker will be sharing her story with us afterwards. Throughout this session, you should be able to use the chat function, so feel free to put your questions in them. Now I'll hand over to Dr. Randev.
Thank you very much, and thank you for that introduction. I'm just going to see if I can advance the first slide, please. Okay. And gosh. Okay. I can't seem to move the slides forward, so I'm just wondering if we could fix that. But while we're waiting for that, and Avitha, if you could sort that out, I will introduce myself. So I'm Pawan Randev. I'm a GP with a particular interest in the earlier diagnosis of cancer. And I've been interested in this field for many years now, going back to when I myself was a GP trainee. I appreciate that most of you are still in the process of completing your training, so I hope that what you're going to learn today is going to help give you perspective, and also I hope give you a sense of some of the exciting and challenging situations that are to come for you when you are working with patients. And this is where I think Helen's insight and experience will be really helpful in terms of understanding what the challenges are. So ovarian cancer is one of the cancers obviously affecting women, and it's a cancer that isn't a common cancer. So the commonest cancers in England at the moment are breast, prostate, lung. Now, ovarian cancer does affect over 7,000 women every year. And with every cancer, we have a way of classifying the kind of cancer that we're looking at. We have a staging system. And stage 1 ovarian cancer is, of course, at the earliest stage, where usually the cancer is confined to the ovary. And within that stage, there is often a very good chance of having a cure. Now, with ovarian cancer, the stages 2 to 3 gradually are progressing so that more of the ovary is involved, and you're starting to reach a point where there is spread of the cancer from the ovary to the peritoneum and beyond. And stage 4 cancer is the stage at which clinically the cancer is very obvious. And that can show itself in the cases that I've seen as abdominal pain, swelling, distension, and all the markers of intra-abdominal pathology. And at that stage, I think any of us would recognize that there is a huge problem and that there is further action to be taken in terms of investigation. The greater challenges arise when we're looking at earlier stage cancer, which is the stage that we're trying to pick up cancers in. And the challenge for us in general practice is that the earliest symptoms can relate to problems which just have vague abdominal symptoms to them. Thank you, Navitha. Just to remind you that this particular webinar does link to an online course. So if you're interested, there's a very good provider of online education on cancer, and they have ovarian cancer modules and also a cervical cancer study module with patient videos and interviews with experts and GPs. Next slide, please. This is what I'm going to be covering today. Next slide. I mentioned the overall numbers, and around 7.5 new cancers every year, with around 4,000 cancer deaths every year. The survival rate is 35%. That's over a 10-year period. And when we compare that to breast, which has survival over a 10-year period of 80 to 85%, you can see the difference. Next slide. The survival is clearly stage dependent, and in both of the graphs, on the left-hand side, you can see stages 1 to stage 4, and at stage 4, the 5 and 10-year survivals are significantly lower. Next slide. And next slide, please. This is a diagram showing the different stages of ovarian cancer. And it may be that whilst you've been in hospital, you've, in your hospital attachments, seen ladies who have been diagnosed with ovarian cancer, or where there's a concern about ovarian cancer and the doctors that you're working with have been involved in investigation and further management. But this staging system is a way of understanding the amount of spread that there is. Now, staging does become much more sophisticated because there are ways of classifying the site of origin of the cells as well from within the ovary, and that then leads to different kinds of treatments that are decided in multidisciplinary team meetings. Next slide, please. Now, one of the things for us to think about, and particularly for me as a generalist, is having an awareness of risk factors and populations. So what are the two biggest risk factors for ovarian cancer? And I've got down here age, family history, the weight, smoking. So what are the two biggest risk factors here? Have a think yourselves. I'm going to tell you the answer, which is age and family history. And then on the right-hand side, there's a question which relates to genetics. And you may not have come across this yet, but there is a particular gene called the BRCA gene, and it comes as BRCA1 and BRCA2. Now, that was the gene that Angelina Jolie has, and she chose in her mid to late 40s to have bilateral mastectomy and bilateral oophorectomy because she had family who had experienced both of those cancers, both breast and ovarian cancer, and she chose to have treatment to prevent that possibility. Now, a little tip for you: whenever you get an MCQ, as this is, with a question about genetics and what's the most common, Ashkenazi Jewish populations for many conditions do have the greatest predisposition, and this represents a long period of genes being shared amongst the Jewish population as they moved around. And so the Ashkenazi Jewish population does have that higher proportion of gene, and there are in fact projects afoot to identify and offer genomic screening for that population. Next slide, please. And next set of questions are which familial ovarian cancer cases, and in fact it's BRCA1 and 2, and interestingly and somewhat counterintuitively, endometriosis and diabetes have a very small impact on the risk of ovarian cancer. Next slide, please. In reality, the major risk factors are around getting older. And this is true of the majority of cancers. Not exclusively, because around 20% of cancer diagnoses can occur in under 50-year-old patients. But in addition, a family history, a condition called Lynch syndrome, or having a past history of colorectal or breast cancer. And this is quite important. And the reason why it's important is that when you undertake your GP attachments, you may well see women who have a past history of breast cancer. And it's worth keeping at the back of your mind that having had breast cancer does actually raise your risk of ovarian and also of endometrial cancers. Weight is a significant factor, and some forms of hormone replacement therapy can play a part. Protective factors include taking the combined pill, breastfeeding, and undergoing hysterectomy or sterilization at an earlier point in your life. However, those factors are either an accidental factor because you've been taking the pill for contraception. The having children breastfeeding is one of these challenges where if you're fortunate enough to have children and you've been able to breastfeed them, it's not something that you can recommend to women. And having a hysterectomy or sterilization also is usually undertaken for other indications. So in terms of protective factors, we don't really have a great deal. Now, when it comes to thinking about presentations, here's a presentation that I've borrowed from the Gateway C toolkit. The reason being that this illustrates a number of points. So Karen, in this case, is 54. She's got a lot going on in her life with her family responsibilities and also working as a support worker. Next slide, please. So she comes to see me as a GP, and her complaints are bloating, abdominal pain, poor appetite, a bit of weight gain, just feeling tired, which she's put down to the busyness of her life, and a recent change in bowel habit. Now, because this is a workshop around ovarian cancer, that's what we think of. But as a GP, I've got a number of other things to consider. And so I have to consider diagnoses such as irritable bowel syndrome. However, it rarely presents for the first time in women over 50. So a first presentation with what feels like irritable bowel syndrome, we need to be thinking, how can we ensure this isn't ovarian cancer? Gastric ulcers can also cause similar symptoms, as can gastritis, both of which are relatively common. Endometriosis, which is a condition with endometrial tissue growing outside the uterus, can also give abdominal pain, bloating, and change in bowel habit. As GPs, we also have to consider conditions such as colorectal cancer. And luckily, nowadays, we have sensitive tests that will help us to distinguish by using a fecal immunochemical test. So the key learnings that I share with GPs and GP trainees are that any woman presenting with a new onset irritable bowel should have a measurement of CA125, which is a marker for. What we do find, though, when we look at women who have been diagnosed with any. My apologies. This is what happens when you've been looking at children with coughs all day. So coming back to this particular case study, many women with bowel symptoms initially go onto a lower gastrointestinal pathway, but there's a really important learning for us as GPs, which is not to, if the colonoscopy that follows in a lower GI pathway is normal, start to think ovarian and start to consider what further investigations we should be doing. Next slide, please. So the key symptoms that we need to be mindful of are abdominal persisting pain and also pelvic pain. And sometimes a symptom diary can help. However, abdominal distension, rumbly tummy, nausea, change in bowel habit over the age of 50, increased micturition. So if you're having to wee more often, as well as obviously thinking about conditions such as urinary tract infection or diabetes, you must consider the possibility of ovarian cancer. Vaginal bleeding can sometimes relate to it, and also sometimes if a lady presents with a DVT, as part of the examination, we do examine the abdomen and pelvis. There are some vague symptoms, including fatigue and unintentional weight loss, but those are less common than the ones on the left-hand side. Next slide. As GPs, we have to see a lot of people, and it can be difficult to keep in our minds the symptoms, the signs, what we should do next. And as a result, there are guidelines produced by an organisation called NICE. That's the National Institute of Clinical and Health Excellence. And a colleague of mine took the NICE guidance for cancer, for every cancer, and managed to condense it into a cancer map. So within this map, you can put the age and sex of the patient, and on the right-hand side, tick the relevant symptoms, and then you get flashing lights coming up to show you which cancer and what the next investigation should be. This resource is available to anyone. So if you just go to Google and put in Gateway C cancer maps, you can have a look at this. And I would suggest that when you are doing your general practice placements, this is a lovely resource that if your trainers aren't aware of it, you can share with them. Next slide, please. So when we look at the ovarian pathway on that map, we can see on the right-hand side with the branches of the tree that someone presenting over the age of 50 with irritable bowel symptoms, bloating, pelvic or abdominal pain, urinary frequency, weight loss, and in fact bowel habit change, then we should be thinking about a CA125, which is a blood test, and ultrasound to rule out ovarian cancer. Next slide. Now, as GPs, we deal with situations where we do a blood test, it comes back raised, we arrange the scan, but the scan comes back normal. And so in that situation, we have to be mindful of the other conditions that can cause a rise in CA125. And that can include other pelvic malignancies. It can include bowel cancer and sometimes gastric cancer. So we therefore have to start looking wider. Next slide. So the other tricky bit is that around a quarter of ovarian cancers will have a normal CA125. And if we're doing a CA125 and it's elevated, we need to organise a scan urgently. Next slide. The other section here, and we've touched on genomics, and I've mentioned the Ashkenazi Jewish population, I've mentioned the BRCA gene, and so therefore it's really important, as we're all taught from being medical students, to take a broad family history of any cancers, and ideally to create a family tree. Gynecological cancers, we need to ask about all of the different types if the patient is aware of what they are and which relative they occurred in. Interestingly, a paternal family history is actually as important as maternal. And there's a reason for that, that men who have the BRCA gene actually are at increased risk of getting prostate cancer at an earlier age. Next slide. So for those women where we have a raised blood test but the scan's normal, we normally think about doing a chest x-ray, checking the stool for blood, thinking about an abdominal CT scan, looking at liver, pancreas, and also with the chest x-ray at lung as being causes of the raised CA125. And this is an important point that I share with GP trainees as well, that it's actually really important to make sure that an abnormal investigation is followed up and at the very least is repeated and ideally investigated further. Next slide. Safety netting is what we call that process, and within general practice we have systems that are in place with our computers that allow us to do that. So next slide. And next slide, please. So I'm working with Target Ovarian Cancer to improve the awareness of ovarian cancer for GPs and also for all healthcare professionals that are providing consultations. There are many things to be learned from the audits and research that Target Ovarian Cancer has been doing. And in particular, I think there's lots to be learned by general practice. And this is where I feel that Helen's story is going to be so important and relevant to us, to myself and to you, to understand that whilst what I've described is the ideal, real life can be different. So Helen, could I hand over to you, please?
Thank you so much. I'm quite pleased to see some of those slides actually, and particularly going along as a 51-year-old woman who's had no problems with IBS before, but then suddenly it being decided that at 51 I have got IBS and not ovarian cancer. But here we go. Anyway, so I'm gonna do this more as a conversational piece, really, about my experience going to my GP and understanding that GPs do have a lot of pressure on them nowadays in time-wise, but basically hoping that somebody, will understand that we have to take ownership of these situations, that there's follow-up and that there's some understanding of the patient. So I'm just going to go through the symptoms of ovarian cancer again, because, if everybody could keep them in their head, that would be great. So the symptoms are bloating. And from a patient's point of view, that bloating never goes away. It's always there. It's always causing you problems. It's not just when you eat. It's there in the morning when you wake up. It's there all day, and it's there when you go to bed. I understand from IBS sufferers that their IBS gets worse throughout the day, and that probably when they wake up in the morning, having not eaten overnight, that their IBS doesn't feel as bad. You don't get that relief with ovarian cancer. It is a constant bloatedness. And then you constantly feel like you need to pee. Now, this varies with lots of different women, because I've discussed it with my fellow sufferers, and some of them felt like they had to go to the toilet quite often, whereas I felt that my bladder just hurt constantly, all the time, as though I had a really bad urine infection. But of course I had that tested, and I constantly test my urine anyway. I can do that at home myself. And so it wasn't a urine infection, but that bladder pain persisted. Could that be that, the disease was starting to affect nerves in my bladder, and that was what was making it so painful. Who knows? But that was my own personal symptom. The other thing is that you have abdominal pain, pelvic and abdominal pain. And this can change a little bit from day to day, but generally is always there. You feel full quickly when you're eating. You soon go off your food, or you feel really uncomfortable when you've eaten. So there I can see the clash with the IBS symptoms. But then the fatigue is unbelievable. It's not just being tired. It's being unable to concentrate, just unable to deal with your day sometimes, despite the fact that you've had a good night's sleep. You wake up in the morning and you're still tired, not refreshed. So my journey started in September 2017, when I just felt really, really tired. That fatigue. Went to see my GP, who checked to make sure that my thyroid was okay. Carry that on now. My symptoms continued until October 2018, when we eventually start with looking at other symptoms, other causes other than IBS or thyroid or hemoglobin levels not being right. And I do have a CA125 test, and this comes back at 99. And so my doctor phoned me up and told me it was 99 and that normal is around about 36. But said, well, don't worry, because in order for that to be anything like cancer, it has to be up in the thousands. Well, I don't know where she got this information from, but I took that on board myself. And it's simply just not true. Each woman has a different CA125 level that she will achieve. So, for example, if I get to a level of 140, that will generally hospitalise me. I'll probably end up with my small bowel being blocked. I end up in hospital, nil by mouth, on morphine, and in a mess. Whereas some of my peer group, their CA125 can be up in the hundreds before that would happen to them. So there is no set pattern, which I'm sure is helpful when you're trying to diagnose it. But if a CA125 is 37 and above, then really that should be rechecked. Obviously we're looking at an ultrasound and check that way. Unfortunately, my ultrasound came back as normal. But my CA125 wasn't checked again for quite a considerable time. And as it turned out, it was edging slowly up. And had somebody kept an eye on that, then they would have known that I had ovarian cancer, or that's what it was leaning towards, because of my CA125 nudging up throughout the months. So eventually I went for a smear test, and that was a real experience. That was in August of 2019. And it was so painful that I had to take painkillers for 2 weeks. I cried. I asked the nurse to stop because it was so horrible. But she said, well, I've nearly finished, so I'll just carry on doing it. And therefore, once again, wandering around in even more pain. So, but what annoys me is that my doctors, it felt like they never listened to me. They just thought, well, here's a menopausal woman who's come in. She's a little bit emotional. Could be that be her hormone imbalance or something like that. Perimenopausal, tired, can't cope. If you'd looked at my notes and knew me as a patient, I had a busy working life, and I never went to the doctors. I never had problems with my health particularly. A little bit of eczema at one stage. I'd never had IBS symptoms before. So why should I present that when at the age of 51 I eventually turn up with health problems? I continually went back, and the symptoms were the bloating. It was the bloating that was the problem, and this really hideous pain in my bladder. And eventually this spread to my hips and around my abdomen. And when I look back at my notes, I actually described this perfectly. But at some point, the CA125 check completely fell off the records, and nobody ever looked at it again. And I'm a calm, sensible, intelligent woman, but I was made to feel as though I was just being emotional, and I never got to see the same doctor each time I went, despite the fact I tried that, and I found it impossible to make a relationship with a doctor that I knew all about me, would listen to me, and didn't have to try and desperately read through lots of notes in the 5 minutes that we had together. So some of my favourite quotes was that I was told that I was perimenopausal and that I'd probably just have to put up with it. Kind of a bit of a therapy session, let her talk about it, get it off her chest, and then she can go about her day. Again, you know, you might just have to put up with it. Yeah, but then nobody actually looked at who I am, you know. Do I complain regularly? Do I go just because I've got a headache? Do I think I've got a brain tumour? The answer is no. Please listen to me. Please listen to what I'm saying about my symptoms. And this just didn't happen. The final GP that I saw, when my stomach was absolutely huge and painful, and it meant that I couldn't sit down and I couldn't lie down. I just wasn't comfortable all the time. I was taking painkillers all the time. And I tried to explain that by this time my stomach was enormous. And she said to me, well, I don't know how big your tummy is normally. Well, that's not up to you as a GP to decide how big my tummy is normally. I'm your patient and I'm telling you it's huge and that it's a problem and that I'm uncomfortable. It's not up to you to decide, you know, how big that is. So she also told me that there was nothing that she could do for me because obviously I'd been to the doctors quite a lot. I could try going to A&E if I really wanted, but it was highly likely that they'd probably just send me home. So I'd actually cried in her surgery at this point because I was in so much pain. And she told me, well, nothing I can do for you, kind of go on your way, really. So I went out into the car park and got into my car and bawled my eyes out, which isn't really me. And then 3 days later, I was taken by emergency ambulance into hospital. I had nearly 8 litres of fluid drained from my stomach. And I was told that I had ovarian cancer. And by this time, I was at stage 3C, 4A. So let me think about that. That was 2017 when I went with tiredness, probably 6 months beyond that when I really started complaining about the bloated feeling and the pain in my abdomen. So we're now talking September 2019, which is 18 months later. And when I look at my notes, there are 2 CA125 tests and one further CA125 test, which appears not to have any results noted against it, and none of the letters say what it is. But my CA125 was at 99. That's significantly higher than the 37, which is a good level. And really, when you look at it, I was explaining my symptoms. Yes, there are other alternatives that could have been, but we'd gone down that path already. Couldn't we have rechecked and rechecked? Or couldn't I have had a CT scan? Now, I understand CT scans are an expense, but when I look at what cost it would have been to have a CT scan for the NHS, when I initially went with my problems, in comparison to the 6 CT scans that I must have at least each year now, if not more, surely that would have been a saving, plus all the chemotherapy that I've had, obviously. So, yeah. In amongst that, I also did go to see a gynecologist. I went to one in Leeds who lost my details and the report didn't come through. And then I went to another one in Harrogate who apparently, when I spoke to them a year later upon diagnosis, said that they'd only really checked my bladder. So that seemed, yeah, a waste of time. Again, no ownership. So what has this meant to me, basically, is that I've given up a job that I love because I can no longer do it. I know now that my prognosis is not great. On diagnosis, and when I had a word with my surgeon, he said that I'd have between 3 to 5 years. And that seems fairly typical from the ladies that I've got to know. And that then means that my youngest child is 21, but it also means that my 3 children will probably get married and have children, and I will never see those grandchildren. I've given up the job I love, and obviously all the plans that I had for retirement with my husband will no longer happen. All my goals and all my ambitions have gone, and I have to look at very short-term goals now. And since my diagnosis, I had 3 lots of chemotherapy, which is the usual, to try and shrink the tumours. You have debulk surgery, which consists of a hysterectomy and an omentectomy, which they remove the omentum because that tends to catch the cancer cells, so they get rid of that. Cervix. In my case, they also took a piece of my diaphragm, and then when they'd taken the diaphragm, obviously my body wasn't very happy about that. So then I had lots of fluid in my chest cavity. So they stuck a huge needle into my chest cavity and drained away the fluid in 2 very large syringes. I stayed very still for that, I'm telling you now. The way they went in was via my shoulder through my rib cage in my back. But since then, because when you are diagnosed with ovarian cancer at such a late stage, it will recur. So whilst after the debulk surgery, I was only NED for about 6 months. And then after that, I've had another 2 lots of chemo, which the side effects of those are hair loss for the initial one, and then there was burning skin, mouth ulcers, neuropathy in my hands and feet, sickness, fatigue like you would not believe, spending a lot of time in bed to recover from it. 3 times I've been taken to hospital with a painful bowel because ovarian cancer seems to love to have an effect on your small bowel and your bowel movement. So I've had blockages there where I've had to be nil by mouth and on fluids and painkillers for a week at a time. And here we are 3.5 years on, and currently my cancer markers are extremely high. We're trying hormone tablets at the moment, but because I don't have the faulty BRCA gene, a lot of the treatments such as PARP inhibitors and hormone tablets don't work on me, and also I lean towards being platinum resistant, which means that the chemo isn't very long acting. So what I'm begging from that is, obviously I'd much have preferred to have been diagnosed much earlier. And I'm saying, listen to your patient, know your patient. Is it somebody who's always coming in with problems, or is it somebody who suddenly has got this huge problem that won't go away? Listen to where the pain is. Listen to how they feel. Use the available tools such as the CA125. But more to the point, how can we do the follow-up? How can we make sure we're following this through? How can we make sure we're looking at the reports and looking at the blood tests, and do we need more blood tests, and are we controlling the symptoms? All of those symptoms should have rung alarm bells, really. Yeah. And more importantly, that then means that at the end of it, you don't have somebody like me on your conscience, because we've been passed from pillar to post, and no consistent care. I know it's really difficult in these times, but what I would ask is to do that, to look after that patient that comes along. Thank you. Thank you for listening.
Thank you, Helen. That's a really powerful account of what you've been through, and so much of your story resonates with having heard other women who have had similar journeys. And I think picking up on some of the key points, and I think probably that the most significant one is to listen to your patient and to hear what you're being told, and not to make assumptions, because assumptions around irritable bowel are possible. But if you have evidence in the form of a raised CA125, then you should be following that up. So your journey started in 2017 to 18, and there have been some changes in systems since that time.
Yeah.
The first being that CT scanning is now more available, but not consistently so. Another being that using and highlighting the need for what we call safety netting. In other words, if you have a patient who comes back with symptoms or has an investigation that needs to be followed up, that is highlighted in the medical record. And I heard you when you said that it was very difficult to see the same person twice. And unfortunately, this reflects the crisis that we have at the moment within general practice in terms of the numbers of appointments that we need to offer. So
can I just interject there? Because since I've been diagnosed, I always see the same doctor, and that is very much possible because my patient notes are marked, and I've been directed to a doctor. What a shame that couldn't have happened before.
I agree.
Yeah.
And I think that if we were able to do that, and some of the work that is being done around safety netting is to allow for that, so that the same professional will set the safety net and then have an email reminder within the system to say, follow this up.
Yeah.
But that's not widespread as yet, unfortunately. And I think the final bit of what you were saying about presenting with a large abdomen, with a tummy that's painful, bloated, clearly not right, I think that should have been handled differently. And there's something within what you're saying which does come back to listening and understanding and being prepared to consider again as a professional what you're hearing and how it fits in with the totality of that individual, of your experience. If you're not somebody that attends the practice often, then for you to come several times, I think really should raise the red flag. But I can see in the chat that Karina had asked either if you've any particular misconceptions or assumptions about ovarian cancer. So really what your knowledge was of ovarian cancer before or during your journey.
None whatsoever, because it's such an unusual cancer, and it is difficult to diagnose. There's just no getting away from that. Because when you go along as a patient, what you're hoping is that you haven't got cancer. Yeah. And so what you do is you grasp to any little bit of information that your GP gives you that it's not. And so when I was told that the CA125 levels had to be in the thousands, I thought, yippee yahoo! I had Googled it, which they tell you not to, and looked to see what a normal level should be. but then was reassured by the fact that my GP, who is medically trained and knows so much more than I do, would know that. So I was grasping to the fact that I didn't want to have cancer. I think that was the main thing. But inevitably, probably by about 18 months before my diagnosis, I knew I'd got something seriously wrong with me. And I mean, at one stage, towards the latter, sort of just before diagnosis, we're toying with the idea of diverticulitis as well. I don't think you named that on any of your slides, but that's quite similar. I have friends who have that, and that is extreme pain when they have an episode. But again, that's an episode. It's not a constant like you have with ovarian cancer. So I just knew nothing about ovarian cancer. That's the truth.
Right. And there's a further question, thanking you for your story, but also asking, through your own experience and experience with support groups, would you have any advice for people who are finding it hard to advocate for themselves? What would you say to yourself, perhaps, at that earlier stage after what you've been through?
Well, it's strange, isn't it? Because I have a daughter who was diagnosed with diabetes when she was 4. And yet again, I came across issues there that when I went to see the doctor, he said that 1 in 1,000 children are diabetic, Helen. What makes you think that it's diabetes? And I had a bit of a fight with them then. And I really stuck up for myself because it was my child and it meant so much. And she went into hospital and we caught it basically before it killed her. And in that situation, I was fired up. There was no way you were going to argue with me. But of course, we come to a point where it's me and I am worn down by fatigue, by pain. I just can't get through to the doctor. I don't know, and I don't know what it is. So had I known it was ovarian cancer, I would have got in touch with Target. Had I known that I'd got cancer, I might have probably gone to Maggie's or somewhere like that and had a chat with them. But I didn't feel that there was anywhere I could go because I have always been the person in the family who's fought the corners for my husband health-wise, for my children health-wise, for my parents. And I think quite often with women of our age and our qualities, we are the one person who would have fought that good fight, but actually we're the weakened ones in this situation and nobody's listening to us. Now that I know what I've got and I know what protocols are in place, what I'm entitled to, I read a lot of not the junk, but the relevant information. I get a lot of support from Target. Then I do very much advocate for myself, almost to the point where I must be a real pain sometimes. But that is the way forward, and I think that's more and more with the NHS nowadays. That's how you have to be, because there is a lot of what do you want to happen? How do you want to look after yourself? And you can't know everything. That's how you rely on a GP so much.
Absolutely. And one other thing that has happened since your diagnosis is that all around the country there are rapid diagnostic centres where when as GPs we're not sure, but we're worried that the underlying cause of abdominal pain or whatever set of symptoms, including fatigue, if we want to rule out cancer, there's a very quick way now, like the referral pathways for cancer, where we can send you to have a CT scan, which would likely have shown that up. But also, as part of the admission criteria to that pathway, you have to have a series of blood tests and other tests. So that would have included CA125. But again, I think that is all well and good. But the very first thing that as a student or as a trainee doctor or as a trainee GP, you have to listen and you have to understand where your patient is coming from and try and do that without any sort of preconceptions on your side. And that, I think, is it does come back to the very sort of foundations of why we've become medical students, of why we become doctors, of why we become GPs. That if it isn't to start with effective communication and effective listening in the first place, then we're not going to get it right. Are there any other questions for Helen or myself? Please put them in the chat if you'd like to ask any further things. While we wait for colleagues to write, just to say that with Target Ovarian Cancer, we are undertaking a series of projects to look at how we can try and improve the uptake, try and improve the speed of diagnosis of ovarian cancer. In particular, Helen mentioned diverticulitis, and there's a project where if a woman over 50 presents for the first time with diverticulitis, then the computer will prompt you to say, hang on, have you considered other diagnoses, including ovarian cancer? I've been working with colleagues in ovarian cancer to create a series of educational videos for GPs, particularly around the situation that you were in, Helen, where your CA125 was raised, but the ultrasound scan was normal. And we talked through with a specialist what you should be thinking about and doing next. And the power of your journey and the way that you've shared it so effectively, I think, is the real meaning of tonight's webinar. I think what I was able to show is what the pathways are and how they should be working optimally, and how, if you as a professional are aware of what you could be doing, are working in a way that allows you to have follow-up within your primary care systems, then you're going to reach a point ideally of picking up serious conditions and being able to do the right things for your patient at an earlier stage, which then makes the difference in quality and duration of life. And you don't get any more powerful a lesson in that than the way that you've presented your story, Helen.
Thank you.
So,
Thank you so much, Dr. Randev and Helen, for sharing your story, and Dr. Randev for beautifully summarizing for us. Does anyone have any further questions? I've just put in the feedback form in the chat. If you could leave us some feedback, that would be very helpful to improve our further events as well. If no one has any questions, then I guess we can end it there. And I would really like to thank Amy, who is on the call, but I don't think she can talk at the moment, who has helped us to organize this event and made all the efforts of arranging Dr. Randev and Helen to be able to be available here to speak today on this event. So thank you so much, Amy. Thank you. And really appreciate all your time and giving us your time this evening. Thank you so much.